Okay, welcome back again, everyone. I hope my audio is okay. Somebody give me a heads up if it's not. But I'm going to be joined by our presenters on this second session, and we will have a panel discussion about their presentation. And I'm assuming my audio is okay, so I'm going to keep going. Thank you very much for the thumbs up. I'm going to actually jump in a little out of order here and ask Dr. Winhun about TNK, because that's actually a topic that's near and dear to my heart. And the primary stroke centers, and on the follow up to the previous session's conversation about interfacility transfers, have really been trying to switch to TNK. And they see that as a promising alternative to alteplase, uh, especially for LVOs that need to be rapidly transferred to a comprehensive stroke center. But we still struggle with the fact that it does not have FDA approval. So I know Kaiser's made the switch, but I'm wondering if you can actually speak to other primary stroke centers that maybe work in more of an isolated environment and really struggle and are nervous about using TNK off label at the present time, especially if they struggle with their transfers to comprehensive stroke centers for large vessel occlusions.
Sure, thank you for that. Um, so I'm aware of a few other centers that have reached out to us in a few other systems, even larger than ours, who reach out to us after they heard that we made the switch over to TNK and share some of our experiences in terms of how to go through the process of presenting the data and speaking to our administrative, legal, pharmacy, everybody that needed to be involved in order for that to happen. I think that it varies quite a bit dependent on obviously where you work and what your system is like in terms of accepting this. For us, we already have a pretty well built-in system of collecting data and was monitoring it ever since we started the Stroke Express program, monitoring our data very closely to know if something may go wrong. We literally review the data every week. And at the beginning, to be honest, as things happen randomly in stroke, we actually had all of our bleeds at that point happen up front. Freaked us out for a little bit. Thinking, whether to continue or not to continue. But since the numbers were so small at that time, we decided to proceed and continue to monitor closely. I think for every system it's a little bit different. We struggle even still within our Northern California system, county to county. So even though we say Kaiser Permanente turn on the switch and we make the switch over to TNK, it's all nice and dandy. We get to call ALS or 911, to transfer our patients. It doesn't work like that for us at every county. There are some counties that are resistant to crossing county line. And we still have a county that will only accept critical care transport for our acute stroke patient, no matter what drug they got. And so we're still working with them on that. It's a continuing conversation, sharing of data. I think as our numbers continue to grow and our safety measure continue to be really good. You heard from Dr. Klingman earlier, when the talk was done, when my talk was done, it was back in March. And, since then we've had a lot more cases adjudicated for safety measures and appears to be quite good at the moment in terms of symptomatic hemorrhage rate or any other complications. So I think as those kind of data continue to build up, we will have more ability to speak with our EMS partners and with other facilities that also are trying to work out how they would do these transfers, et cetera, that we can share these things and share our learnings and say, this is where we find that so far so good, and the data and the numbers back us up.
Very
so I
good.
think that's where it's going to go.
Yeah, I really appreciate that. And I have a feeling we will have this topic on the agenda next year for our second summit. So maybe you'll have more information for us then. I want to jump over to this conversation of COVID and strokes. I think initially got a lot of attention and people were very nervous. I think a lot of the questions remain essentially unanswered, but I'm just wondering, Dr. Rao, is there a connection that we're seeing with vaccination as it's ramping up and COVID becoming less and less of a factor in our communities, and strokes in terms of volumes and complexity and severity?
Great question, and thank you again for inviting me. And I hope we have the opportunity to talk about this next year as well, because I think that will be the more clearer time to answer your question. We have yet to vaccinate more than 50% of our population in many states, and in certain counties we're certainly above 50-60%. So we don't know. I don't think I know, and I'd love to hear from our co-panelists here who work in other parts of the country and can speak to this in their realm better than I, whether vaccination rates and the hopefully concomitant decrease in severe COVID will be associated with decreased association of COVID and stroke. I think time will tell. Overall, my opinion is that COVID will become one of these chronic virus that we have to vaccinate against every year, and there will still be some people who get it, and as a result we'll have to always be vigilant and keep an eye out for those who develop the severe forms of COVID, and those patients who have that hypercoagulable state in the NICU, who are on heparin and have PEs and what have you. That population probably is always going to be more prone to developing ischemic strokes. But there is this middle ground of patients that I don't think we fully understand, and I don't know whether that middle ground will still exist after vaccination. That middle ground being the people who are a week or two after their infection, they're doing pretty well, and they suddenly get a stroke. And they might have a couple of risk factors, but they're in their 40s and 50s and generally healthy, and you didn't expect them to get a stroke, and they have a large vessel occlusion, they show up. That population, I don't know if that population will still exist when vaccination is more common. And I'd love to hear from Jeff and you and others about what your thoughts are on that, because I think that's going to be an interesting population to study and track over the next year.
Yeah, I suspect you're absolutely right. I think we need a couple of years to really wait for the data to mature on this, and we have a better idea what the relationship between COVID as an infection and stroke is. So again, I suspect this item will be on the agenda next year too. So I look forward to that. Dr. Saver, I want to turn to you if I could. I found that helmet technology very, very cool. And I'm wondering, what is the status of marketing and approval for those devices in the United States, and are they being used elsewhere right now?
Well, none of them are approved for use in the US. None of them are quite ready for prime time, but they're getting closer and closer. The vibration technology just started a first clinical study with EMS paramedics in Detroit. And the ultrasound technologies are also designing their pre-hospital studies right now. So I'm hopeful that within about 2 years, we may see these come to market and into our hands.
Yeah, very cool. And then can you briefly comment on any novel neuroprotectants that might hold a promise for EMS use, or maybe the answer is just no?
Well, currently the most promising one is Narinitide, NA1, which is an indirect blocker of excitotoxic injury. And it showed promising results in a large clinical trial in Canada when given after hospital arrival. And it is being tested in the Frontier trial in Canada in pre-hospital setting, being given to about 500 patients. And the results from that should be available in 1 to 2 years.
Fantastic. Thank you for that. Dr. Nogueira, I'm curious, after listening to your presentation, it is clear to me that the push is the expansion of indication for endovascular treatment when it's appropriate and shows promise. The question that comes up as an EMS medical director is, what do you anticipate the impact of this would be given the conversations we've had this morning about patients in the field being identified as large vessel occlusion and determining their candidacy for thrombectomy kind of procedures?
So I think that we still have to define the future of the pathways in terms of facilitated thrombectomy with IV thrombolysis versus direct thrombectomy. About 2/3 of all strokes have NIH 0 to 5, right? So the so-called mild strokes. And out of these, about 20% or so will have a large vessel occlusion. So if you can tap into that patient population in terms of a proportion of patients, it would be a big add-on. The other population that sounds very promising is the large stroke size, right? So right now you are excluding patients with large strokes. And that is true, the chances of them achieving a good outcome is probably not very high, but the question is, can they achieve better outcomes? Maybe not a home run, but you can prevent a hemicraniectomy or have somebody that wouldn't be able to walk and would be bedridden being able to walk. So we are in the process of expanding these patient populations. But one of the paradigms that I didn't have time to get into detail that might be very important for EMS to at least understand it's being explored is the idea of bypassing imaging upon arrival to a comprehensive center. So right now, the pathway is that you go to an imaging suite, most commonly CT rather than MRI, and then you have CT, CTA, oftentimes CTP, that adds about 30 to 45 minutes of time, which is very different than you see in cases of ST elevation MI when patients go directly to the angio suite. So there are trials about to start that they're gonna test the hypothesis that bypassing imaging and saving those 30 to even 60 minutes could lead to better outcomes. And I think if that's the case, you're gonna be potentially looking at what you're seeing with MSU for intravenous thrombolysis. The sooner you treat patients, the better the outcomes will be. And then you're gonna have to rebalance again the options in the field versus, when you're thinking about what are the traveling time that it's acceptable to a CSC versus a PSC. So a lot of things happening in the future. This story is not yet fully developed, but a lot of promising new strategies to treat stroke patients.
Very good. Thank you very much. That concludes our question and answer session for this group of presentation. I want to thank our panelists and presenters for their time and their presentation. There are a number of questions that we will not be able to get to, but hopefully we can try to get some answers for those, or definitely as ideas for our next year's agenda lineup for this conference. So with that, we're going to be in a break until, until 10:35. And again, thanks to our panelists and presenters, and thanks for the attendees and their questions.